Hello, everyone, and welcome. We're so glad you could join us today for Preeclampsia, Pumping, and Postpartum Care, a call to action for perinatal nurses with Dr. Diane Spatz. We are truly excited to have such a large audience with us today. This level of participation reflects just how relevant and important this topic is to healthcare providers caring for families in the perinatal period. Throughout the presentation, we encourage you to submit your questions at any time by typing them in the questions pane of your control panel. We will be collecting your questions and addressing as many as possible during the Q&A session at the end of the webinar. To help get the most out of today's session, you can interact with the toolbar panes for handouts, polls, and questions. You will find event handouts, including your certificate of attendance, in the handout section of the toolbar. If you experience any technical issues during the webinar, please click the Help button on the bottom lower left corner of your screen for assistance. Please note today's webinar is being recorded. After the event, you will receive a follow-up email with a link to view the recording at your convenience. And now it is my pleasure to introduce today's speaker. Dr. Diane Spatz is Professor of Perinatal Nursing and the Helen M. Shear Professor of Nutrition at the University of Pennsylvania School of Nursing, as well as a nurse scientist lactation specialist at Children's Hospital of Philadelphia. She has served as a principal investigator or co-investigator of more than 50 research grants and has authored or co-authored over 280 peer-reviewed publications. In 2004, Dr. Spatz developed the 10 Steps for Promoting and Protecting Breastfeeding in Vulnerable Infants, a model now implemented in NICUs across the United States and around the world. She is an American Academy of Nursing Edge Runner, serves as treasurer for the International Society for Research in Human Milk and Breastfeeding, and was appointed to the National Academies of Sciences, Engineering, and Medicine Breastfeeding Analyst Study in 2024. Most recently, in 2025, she was honored with AWAN's Lifetime Achievement Award. Dr. Spatz, we are honored to have you with us today and look forward to learning from you.
Thank you, Jessica. Well, it's a pleasure to be with you today. This topic is something that is near and dear to my heart. My background as a nurse has always been caring for high-risk pregnant people and babies. And my master's degree is in perinatal nursing. So this has been a topic area that I've been interested in ever since I was actually an undergraduate nursing student at the University of Pennsylvania. We have two main objectives for today, looking at the connection between breastfeeding, cardiovascular health, and long-term risk reduction, and then best practices. I do want to acknowledge two people. Dr. Adrian Burgess is a good friend of mine from A1. We did a talk in June of 2024 about severe maternal morbidity. So a little bit different than this one, but I did use some slides from that talk for today's webinar. And Adrian's pictured at the top. And then Holiday is my PhD student. And we have an integrated review in press that I will be talking about. So we're going to start right off today with a polling question to get a pulse on the audience to see how frequently people work with patients with hypertensive disorders of pregnancy. So if you could take a moment to answer that poll, and if you don't care for these types of patients, you can just select never. So how big of an issue are hypertensive disorders of pregnancy? You can see from this study here in citation, the three top reasons for ICU admission in pregnancy: hypertensive disorders of pregnancy, OB hemorrhage, and sepsis or infection. So we do know this is a growing need for us to be able to care for these patients. The amount of chronic hypertension has significantly increased over time. And that is largely due to the increasing rates of obesity and also increased maternal age. So these women who have hypertension are at risk for having high risk pregnancies. And we also have to worry about them having superimposed preeclampsia. Here you can see the trends in new onset hypertensive disorders. Really, the rates have gone up exponentially, right? And so we do see differences in urban versus rural areas, but in either case, no matter where someone lives, the rates of hypertension are really going up statistically significantly. Now, this is of concern because when we think about this, these pregnancy related hypertensive disorders also really put not only the mother at risk in the future, but it also makes the pregnancy be more complicated. And so we can have higher rates of admission to the NICU. We can have higher rates of morbidity for the infant. And then for the mother herself, she has higher risk of having cardiovascular disease as she ages after her pregnancy. She can also be at risk for stroke as well as even death. So when someone has both hypertensive disorder of pregnancy and they have it indicated preterm birth, i.e., we have to have them give birth early, this significantly increases their future of heart disease, hypertension, and again, morbidity, and even potential mortality. Now, I found this study, which was conducted in Australia, actually, very, very, very concerning. Because what the study looked at was healthcare provider knowledge and also parent provider knowledge about the risk of cardiovascular disease after having a hypertensive disorder of pregnancy. And there were 12 studies included, 402 women and over 1,200 healthcare providers from 7 countries. So even though the authors were from Australia, it was looking at global data on this. And there were 7 studies that specifically looked only at women, and women didn't have any or limited knowledge. And the women who actually had any knowledge at all did not get it from their healthcare provider. They got it from friends, family members, and social media. And then what is even further concerning is healthcare providers also had a limited knowledge about hypertensive disorders of pregnancy and future cardiovascular disease. So to me, this is a tremendous call of action, right? We need to make sure we as nurses know this information and that our parents are getting this information before they even give birth. Heart disease is indeed the leading cause of death for women in the United States, and is responsible for 1 in every 5 female deaths, right? So this is a true public health crisis. So this is where we can think about breastfeeding and what is the role of breastfeeding in keeping parents healthy. We do know research done by my colleague Adrienne showed when she looked at national data, okay, women who had hypertensive disorders of pregnancy were significantly less likely to initiate breastfeeding or pumping, even for a short period, compared to women without hypertensive disorders of pregnancy. So women report reasons for not starting breastfeeding is because of disease or illness, or thinking that their medications are not compatible with being able to breastfeed. So think about this. These women are at higher risk for cardiovascular disease later in life and high blood pressure. Yet we know breastfeeding protects women from future cardiovascular disease and hypertension. So we need to have parents understand that it's important for them to breastfeed their babies. There is a significant difference and both systolic and diastolic blood pressures between those who initiate breastfeeding and or pumping and those who do not. And again, this is some data from Dr. Adrienne Burgess's research, okay? So parents need to be educated that lactation is important for reducing blood pressure and for good heart health. So these parents are not without challenges though, right? Because when we have a pregnancy disorder of hypertension or severe preeclampsia, we can face many challenges. We might have separation from the infant, either the mother going to ICU or baby going to ICU. When a parent does go to an adult ICU, breastfeeding or lactation is many times an afterthought. And people are worried more about the mother surviving or taking care of the mother versus breastfeeding. So surviving preempts breastfeeding. So this is a lovely conceptual diagram from a study. It was a randomized trial looking at improving self-efficacy and breastfeeding outcomes for people with hypertensive disorders of pregnancy. So this is a study protocol. It's not actually the results of the study yet. It was what they are planning to do. So the results of the study are not actually out yet. But I think it's a really nice schematic because we can look at, the fact that these hypertensive disorders of pregnancy make parents at future risk for future chronic hypertension, metabolic syndrome, cardiovascular disease. We know that breastfeeding can be very difficult. If we could help people have a better lactation journey, then we could have the positive effects of that breastfeeding journey on their future heart health, their blood pressure, right? And we know breastfeeding has so many benefits for the mother herself and her future health, and then we can improve her long-term outcomes. So it's very, very clear that lactation is protective, right? It's very clear. We have decades of research about the importance of it. But we also have an equal amount of research, and I'm going to talk a little bit more about this in a moment, about how challenging it may be for someone who has one of these diagnoses to actually have a long lactation journey, okay? So this means we have to change the current paradigm of how we practice, and we need to think about the best practices for these families that nurses can really control. Perinatal nurses are the leaders to help ensure positive lactation journeys and improve cardiovascular health and decrease blood pressure. So what are the best practices we want to consider during pregnancy? What things should we be doing as perinatal nurses? First of all, we need to prepare for lactation during pregnancy. And I don't know if any of you have read the breastfeeding analysis study yet, but if you have not, I would 1000% recommend that you read that. As Adrienne mentioned in my introduction, as Jessica mentioned in my introduction, I was part of this national study. And it's a very clear report about what we need to do to improve lactation services in the US. We do know that implicit biases and structural racism continue to exist surrounding lactation in the US today. We know that all people don't have equal access to services. So making sure every single family within your care has evidence-based information, breast pumps, access to IBCLC care, home visits, access to donor milk, and access to support services. So there's key recommendations in that report that you should take a look at. Pregnant parents with hypertensive disorders of pregnancy really need to have all of the following three things. We absolutely have to teach them why human milk and breastfeeding are essential life-saving medical interventions. My 10-step model that Jess mentioned in the beginning, the first step of it is informed decision making. We know that not all parents come into pregnancy thinking they want to breastfeed. For parents with hypertensive disorders of pregnancy, it's essential that they are educated about lactation and human milk, both for their infant, but also for themselves, right? Lactation and breastfeeding is critical for the future health of the mother in preventing cardiovascular disease and hypertension. And then beyond just the mother, we need to be working with the family. No person should be on their lactation journey by themselves, right? So we need to educate the family about the science of human milk and the physiology of lactation. And we want to adopt a proactive lactation management strategy starting in pregnancy. Again, perinatal nurses are the best people to educate families about the science of human milk, right? We need to be talking to parents about what's in human milk that their baby is never, ever going to be able to get from an infant formula, right? And so human milk, these components impact every organ in the baby, right? They impact the brain, the eyes, the lungs, the heart, everything, right? And so we want to teach families about that science of human milk, those ingredients, the dose response. We want them to know that fresh milk, milk that has never been frozen, milk that isn't pasteurized, is going to be the most potent milk to feed their child. Another best practice is about educating families about secretory differentiation. Many people think they don't have any milk in pregnancy. They think they don't have any milk after they give birth. But in fact, secretory differentiation starts at 16 weeks of pregnancy. So even if someone gave birth at 22 weeks, which is the current point of viability, the breasts were already secreting milk since 16 weeks. So the milk is always going to be there no matter how early someone gives birth. We may want to also consider antenatal milk expression. Nina Gentriel and I published an integrative review about antenatal milk expression looking at 15 worldwide studies. We know the practice is safe. We also know that it does not cause harm, like early admission, and that people may be able to harvest small amounts of milk, which can then increase their confidence in breastfeeding. So we were able to demonstrate that when parents began antenatal milk expression at 37 weeks, they were able to harvest or save small amounts of colostrum. This milk was collected using a small oral syringe. It was then labeled and frozen and stored at home until the parent came in to give birth with their infant that had a congenital anomaly. Again, appropriate guidance is that it's only going to be small amounts of colostrum that can be collected. Another best practice in pregnancy is to teach the family about realistic expectations. In the integrative review we did about antenatal milk expression, there was a presumption that it would make the milk come in quicker. But antenatal milk expression does not result in earlier secretory activation. And that's really important because remember, you cannot go on to full-blown milk production until the baby comes out and until the placenta comes out. The placenta has to come out in order for us to go into secretory activation. So even though it doesn't speed up secretory activation, it does help the family being happy with knowing that they could make milk. They knew how their breasts work. They had colostrum available for their baby. And that knowledge of knowing the physiology of lactation. And we did use lactation biomarkers in this study. So we could actually really track secretory activation and when people came to volume. So the next best practice is being aware of the impact of magnesium sulfate on lactation outcomes. And as I mentioned, Holiday is my doctoral student and Dr. Clark is on her committee. And this should be out, I would think, any day now in breastfeeding medicine because we just reviewed the proofs last week. So over a decade, there were only 10 studies, over 2 decades, 1993 to 2023. There were only 10 studies identified. So this tells you how little attention has been paid to hypertensive disorders of pregnancy. You can see that the studies included RCTs, case reports, and cohort studies. Okay, so different levels of evidence, but we were looking at the study aim and the breastfeeding outcomes. So the pieces that we examined related to these 10 studies were breastfeeding intention, how they initiated breastfeeding, breastfeeding at discharge from the birth hospital, any studies who reported breastfeeding after discharge, which was only 3. There were only 2 reports of perceived secretory activation. So there was no actual measurement of secretory activation in any of the research to date. And then a small amount reported the type of lactation support people received. So there's 2 particular researchers I want to mention from this review. One is Cordero's work, and they have 2 publications, one from 12 and one from 21. But in this particular publication, they looked at severe late onset preeclampsia, so people who needed MAG versus people who did not. And then they looked at the breastfeeding rates at discharge from the birth hospital. And you can see the significant difference between those who did not need MAG and those who did. And one of their conclusions from their study is milk expression was what allowed people with MAG treatment to actually provide milk for their baby, because their babies could not feed necessarily directly at the breast. Less than half of them fed directly at the breast. And then the other one is from Dr. Adrienne Burgess, and she looked at people with early preeclampsia versus late preeclampsia and their outcomes. And you can also see from this table that there are several really statistically significant differences in outcomes. So there was significant differences based on racial status, looking at BMI. There was some significant difference on intent of whether or not they wanted to breastfeed prenatally. MAG sulfate was statistically significant. And then you can see that negative effect of type of birth, and that there were differences in breastfeeding outcomes, both at discharge and at the postpartum visit. So we need to be aware that with the worst severity, we're going to need to do more intervention. MAG has a negative impact, right? And any labor and delivery nurse, postpartum nurse is going to be able to tell you that. And you can see in these research studies, there was usually a pretty high dose of MAG, except for a few that were doing intervention group studies to try to reduce the number of hours. But being on MAG for at least 24 hours or more delayed breastfeeding. 2 more key findings are the NICU admission rates, right? And they were quite high, and the cesarean birth rates compared to national data. So we know we're having disruption of normal physiology and normal lactation. So there's negative breastfeeding outcomes in terms of both initiation, intent, being able to effectively initiate breastfeeding directly at the breast or pumping. And then when we don't effectively initiate, then we have a higher risk for breastfeeding cessation. And then we also have these challenges of how hospital protocols could restrict the ability for people to breastfeed or to be able to express milk for their baby. So there is some critical questions to consider, and this is what we hope to be able to answer with Holliday's doctoral research. What is not clear from any of the literature, because of the way that research has been done and variables that have been measured, is that are the lactation challenges due to the pathophysiology of the hypertensive disorders of pregnancy? Or is it the side effects of magnesium sulfate and the medication itself? Or is it the care that people receive or maybe don't receive, meaning help to attach their baby or help to pump or early lactation intervention? And kind of those three questions, it could be a little bit of all of them. But right now, we don't have the answers in research done to be date. So now we have two more polling questions for you. The first is, if you work with patients with magnesium sulfate, if their baby is separated from them and the baby has to go to an ICU or a different unit, how soon are your parents who are on mag sulfate beginning pumping? And please be honest with your answer. And if you don't care for this population, you can just choose that option. The second polling question is, when you are caring for patients who are on mag sulfate, are they allowed to breastfeed their baby? So like if the baby isn't sick and is able to directly feed, are we helping with that immediate breastfeeding session and breastfeeding sessions in the postpartum period, even when they're on mag, or are they not? And again, please answer honestly. So, given everything we've learned so far, let's talk about best practices, right? What are the best practices after birth for assessment, education, interventions, and care? And really, this is a call to action for the perinatal care team to proactively manage the initiation of lactation. So, in addition to hypertensive disorders of pregnancy, these parents probably have many other risk factors as well. And so if you're not familiar with the call to action that we did, this was an international collection of midwives. So Jessica Brimley, she is the president of ACA, American College of Nurse Midwives in the US, and then midwives from around the world. And if you look at this table here, which is from this article, you can see all the other risk factors. So the age, the BMI, the diabetes or gestational diabetes. And so we know from the literature about hypertensive disorders of pregnancy that many people who have hypertensive disorders of pregnancy also have other risks, like their body mass index, like diabetes, and potentially their age as well. So we need to be assessing and documenting those risk factors on admission to the birth hospital during labor and birth, in the postpartum period. And those risk factors should be communicated through the healthcare team. Again, another best practice is to pump early and pump often. Dr. Rebecca Hoban, she's a neonatologist. She recently published a sample of 143 pump-dependent mothers. So these were mothers who had preterm babies, and they were pump-dependent. They had to express milk via pump. And of her total sample, just over a third, 35% of them had hypertensive disorders of pregnancy. But what is really important from her work, and has been reflected in other people's work, including my own, is that even with lactation risk factors, the daily pumping frequency, meaning pump early, pump often, is the significant independent predictor for lactation outcomes. So, best practice, again, involvement of the family. You want to make sure you're assessing the family's understanding of how human milk is a life-saving medical intervention for the child. You want to assess the family for their understanding of the importance of lactation for future maternal health, right? And protecting her heart and her blood pressure. And then we want to involve those family members in the education, decision-making, and care. So, for example, if the parent is too sick or unconscious, that family can be the people who are assembling the pump, operating the pump, and holding the flanges to the breast for milk expression. This is our job sheet that we created at Children's Hospital Philadelphia. We did this a long time ago when we published our Pump Early and Pump Often manuscript. So that is available to you as well. And this job sheet is in that article. So this is something that you can adapt for use at your own institution. We found that our parents very much appreciate the partners being involved. And in fact, I've had family members contact me after discharge saying how much their partner really embraced that job list. So we put them in charge of everything related to pump operation, assembly, cleaning, labeling, storage, starting oral care with their baby with human milk. Now, best practice, again, in labor and birth care, if the parent is stable and the infant is stable and does not require transport to the ICU, either mother or infant, we should have that baby skin to skin, and we should be attempting breastfeeding. We would also want to initiate pumping right away after birth due to the risk factors for delay in secretory activation, right? So absolutely skin to skin, absolutely breastfeed. But again, also adding on that milk expression to get that stimulation, that vacuum to turn on the prolactin receptor sites. Best practices during the postpartum, right? Postpartum nurses, keeping that parent and infant together, having that baby be skin to skin. A lot of times when I go to birth hospitals, I see babies skin to skin maybe in labor and delivery, but the rest of the time they're wrapped up in a crib like a little baby burrito, and they're never skin to skin again. So keeping the parent and infant together, prioritizing skin to skin, prioritize having the pump at the bedside and pumping around the clock, including at least once at night. And remember, these babies will have been exposed to a lot of IV fluids during labor and birth, due to the magnesium sulfate, due to the interventional birth, due to maybe getting also Pitocin, lots and lots of IV fluids. So these babies are very wet when they come out. So they pee a lot, they diurese, which causes them to lose weight. And then when they lose weight, providers say they need to supplement. And so they're at high risk for supplementation. So if the infant does require supplementation, using pasteurized donor human milk versus formula to keep that microbiota intact and protect that baby's brain. If the birthing parent goes to the ICU, we need to make sure a pump is there too. We have pumps galore at Children's Hospital Philadelphia. I will say when I was recruited there in 2001, so that's what, 25 years ago, 25 years ago in 2001, CHOP owned exactly 4 breast pumps. 4, that's it. Now we have over 400. Again, having the pump at every bedside saves money, and it makes it easy to express. So we have to get that pumping in the first hour, the first 6 hours, the first 24 hours, the first 3 to 5 days. And if the family is not available, the nurse has to be the one who helps with pumping or solicit the help of another health member of the healthcare team, for example, a medical assistant or a tech. And then you could also consider a hands-free bra to help with milk expression. Again, another best practice is making sure we have appropriate pump technology. Many people get free pumps from their insurance. However, they're not computer chip pumps. And we know that the best practice to get colostrum is to use initiation technology because it removes colostrum more effectively. So that means we can start feeds earlier with human milk for the baby, and it means we can come to volume more efficiently. Another best practice is the monitoring and frequency of milk supply and pumping. Now, I include this article specifically because it is a historic piece that is just so significant. We've known this information for 20 years, okay? 20 years, right? And we still have hospitals and nursing staff who don't prioritize early frequent milk expression and tracking of milk volume, right? So the Institute of Medicine says it takes 17 years to get research translated into clinical practice. This has been published over 20 years ago. And this historic research is also supported by modern day research where we use those lactation biomarkers, i.e. measuring sodium and lactose, like Dr. Gentryell did in her research, like Dr. Hoban did in her research, like this article where they looked at the first 5 days. And this is a small sample, it's a pilot 29. Okay, parents who pumped at least 5 to 8 times per day were more likely to come to volume. And again, those with the most frequent expression sessions in the first 5 days came to volume more quickly. So again, best practice, early frequent milk expression. We need daily education and assistance. If you want to improve human milk at discharge and beyond, every nurse has to be giving the same messaging and assisting with breastfeeding and pumping. And so this is our Pump Early, Pump Often project that I mentioned, where the job sheet is published in. You know, when we opened our special delivery unit, we had protocols in place. We had policies in place. But just because we had them in place didn't mean people were doing that. And we had to do quality improvement to make sure every single member of the healthcare team, every single nurse was giving the same messaging and was giving the same assistance with breastfeeding and pumping. Remember, the integrative review by Holiday and myself showed that there are higher rates of cesarean birth with hypertensive disorders of pregnancy. And so cesarean birth, we know, has been reported as a reason that we have delay in secretory activation and that we can have challenges with breastfeeding initiation. So at Children's Hospital of Philadelphia, we were able to bring the pumps into the operating room, and our cesarean birth moms were pumping just as quickly as our vaginal birth moms. And it is actually possible and feasible as long as we prioritize it and we have resources such as a pump at every bedside and in the OR, and have the staffing investment. So that leads me to talking about this study about cesarean birth. When we did our Pump Early, Pump Often project, we found actually that our cesarean birth moms had more milk than our vaginal birth moms. Peter Hartman was still alive at the time, and I took my data to Peter and I said, look at this. What do you think of this? And very thoughtful Peter is, and he's like, this is so important. You better do a study on this. He's like, I'm actually not surprised at your findings because all of your moms at CHOP are effectively initiating lactation because I know that's something you prioritize. But he said, please, please, please do a study on this. So we did. I always listen to anything Peter Hartman ever told me to do. So this was a very large cohort of families who had cesarean birth, 468 dyads. We looked at the time the baby was born, the time the placenta came out, and then how quickly they initiated lactation. And so again, these are all mothers who have sick babies. All the babies were going to ICU because they had congenital anomalies. And you can see that we had a very high rate of early initiation of 90%. We only had a small group of outliers after 6 hours. So nurses and nursing care has to prioritize the initiation of lactation, even if the lactating parent is sick or the baby requires ICU admission. Again, significantly important because just like in Dr. Hoban's work, the research shows that even if people have lactation risk factors, the early frequent pumping is what overrides risk factors. So that messaging has to be very clear. Again, if the baby requires NICU admission, the NICU nurse has to prioritize that early frequent pumping. this little data collection tool I have shown here in this picture, I've used this all over the world in low and medium resource countries where there's not electronic charting, where resources might be more limited. And this is actually a picture from Botswana. When we've had nurses, NICU nurses, because again, they're the ones who are with the parent the most, because the parent's not going to stay up in postpartum, they're going to want to come to see their baby. When we've had nurses around the world focus on the day of birth and the first 4 days, that's when we've seen NICU human milk rates at discharge go up threefold. For example, in Botswana, when I started working there in 2020, our human milk rate at discharge was only about 1 in 4 babies. Sorry about that. And now the human milk rates at discharge are about 70%. Okay, so again, if you want to increase long-term breastfeeding outcomes, we have to focus on delivery day, birthday, and the first 4 days. Again, best practices for people who have hypertensive disorders of pregnancy, we really should be having daily assessment and intervention by IBCLC teams, okay? The same international work group I mentioned to you developed a call to action with pathways. So this is proactive management. There are 2 free clinical pathways included in this article. And again, thinking about the role of the IBCLC in prioritizing seeing these families daily until a parent comes to volume and milk supply is established. We also have to be mindful and think about the post-discharge period. And unfortunately, we know that in pediatric primary care, oftentimes parents get told to supplement their baby if the baby presents and isn't feeding well or has lost weight. Formula supplementation is the first recommendation often. This is an article about protecting milk supply for primary pediatric care professionals. It comes with a free handout that you can access through the article. So future research needs to look at things both from a qualitative perspective of both parent and healthcare providers, experiences, barriers, opportunities. We need to look at accurate measurement of secretory activation and using lactation biomarkers. We have to consider the dosage and duration of magnesium sulfate on secretory activation and coming to volume, and then looking at short and long-term breastfeeding exclusivity and duration. And this is also an area where quality improvement could be used to have programs that support lactation initiation in parents with hypertensive disorders of pregnancy. So thank you so much. This is my last slide. My best contact email is on the slide. And then I'm also just going to put in a plug in for the International Society for Research in Human Milk and Lactation. Our conference is going to be held in beautiful Munich, Germany in October. And you can become a full member of ISHML if you are a researcher in the field of lactation with publications, or you can become an associate member. You don't have voting privileges, but if you're just super into research and human milk. So thank you so much and have a great day.
We had so many great questions, Diane. Thank you so much. It was such a great presentation. And one of the things that I thought was really fascinating is when you talked about, like, we've known for 20 years about tracking daily milk volumes and making sure moms get to 500 mils per day by day 14. I'm just wondering from the audience, like, how many people actually um, do that? And why do you think we have such a barrier to practice, Diane?
Well, golly, we could have made that another polling question, right?
Yeah.
Um, but this is something, I think about the fact that I got my PhD now 30 years ago, and my very first NIH study was about factors impacting milk volume and improving that experience, right? And so we knew all that time ago that early frequent milk expression was critical. And it is really hard for me, honestly, I was just talking to someone earlier today about this very topic area. Like, why is it that we still have people not understanding that sense of urgency we have to have? I do think it does come down to education. If nurses and physicians and dietitians and healthcare providers don't really receive education about the science of human milk and the physiology of lactation, then they might end up not prioritizing, right, pumping early and often, or they might give people bad advice like, well, you should sleep and get some rest because you've been through a lot.
So one of the questions that came up a bunch of times, Diane, was this idea of pumping somebody unconscious that might be in the ICU and what like maybe level of consent we would get or how do we even broach the subject when somebody's, on a ventilator and have multiple things going on. I know I've done it a million times in the ICU, so just wanted to know what your thoughts were around that.
It's a great question. I mean, I think that hopefully when the person was pregnant, someone asked them about their feeding intention. And if they were asked about their feeding intention and their feeding intention was documented in the medical record as breastfeeding, that then tells us that we should be beginning milk expression for that person, even if they're in the ICU. I've been a perinatal nurse my entire career. So I too have had these experiences of, very ill women and needing to help them express or have their family members help them express. I have already gotten phone calls and emails from clinicians around the country about this very question. But again, I think part of that goes back to, this idea like, and I had this in one of my slides, like, well, when someone is sick, survival kind of becomes the most important thing, and breastfeeding is thought of as an afterthought. However, if you really look at the science, right, and how significant lactation is for heart health and blood pressure, right, and the metabolic reset, and all the things that breastfeeding does for us, right, that means like just because the person is sick, we can't be like, oh, we'll worry about that later, because we can't worry about that later. And, I unfortunately was not breastfed as a child. My mom didn't have the opportunity to make an informed decision. And let me tell you, every day I worry about my risk for heart disease and diabetes and a high BMI. And, I constantly am an exercise fanatic and everything because I didn't have that. I don't have that protective effect, right? And so I always, talk to people when I'm teaching them, right? How many things in life can you have such a positive impact on both the baby and the mother, right? Because think about the fact that babies are protected against diabetes and heart disease. And like, it's like, wow, we're getting a 2-for-1 where we're protecting both the parent and the child. And so I understand where people have, concerns like, is this okay to do to a person who is unconscious or is sick? But again, even if the intent for breastfeeding wasn't documented, this is where we have to involve the family. If someone is sick in the ICU, someone in their family is likely there. And that's
Yeah.
where I think we also, if we're the ICU nurse, have an obligation to talk to the family about why lactation is important for their baby and why lactation is also important for that mother's future recovery and preventing future risk in terms of morbidity or mortality to her.
Yeah, and I think it's such an important point because for every time this has happened, the mothers are so grateful that you took the time to protect their milk supply. And if we let them go 24 or 48 hours without pumping or any kind of stimulation, you've really taken that choice away from them as well. So, I mean, I think that's another way of thinking about it. And there's another question in the chat, kind of along that line, and it's about being the postpartum nurse, right? And she said, as a postpartum registered nurse in IBCLC for 40 years, I've experienced the labor nurses are the ones that are worried about their moms and put milk on the burner and won't listen to the importance of what we have taught them. And this was actually the big reason why we wanted to do this webinar because, again, there's not always this knowledge, and you pointed this out earlier in the webinar of even the nurses, the doctors, the mothers don't understand how protective this is going to be for the mother long term. So, what kinds of advice do you have for Nancy when she's dealing with the nurses in her unit?
Well, everyone should have a breastfeeding resource nurse program like the one that I developed at CHOP. That's what I'm going to say. I really, I mean, I'm saying that in a joking manner, but honestly, it's like if every member of the healthcare team doesn't get that scientific base, then people can make poor decisions, right? And so I really think it's so important for all of us when we're talking about lactation, whether it be the benefit for the child or for the parent, that we're really leading from a science-based way of speaking, right? And really being very precise about research demonstrates these findings. And this is why, as a labor and delivery nurse or a postpartum nurse or a NICU nurse, this is why we need you in that role to prioritize the lactation journey, right? Because this is not just a US problem, this is a global problem, right? And many times people might hear that breastfeeding is good, or they might, have BFHI training that focuses on the baby comes out, the baby latches on, the baby skin to skin, all which is great if we don't have any complications. But a lot of people don't have that science knowledge about, okay, if everything doesn't go how we expect, what do we do then? And that's where we have to really lead with science.
Yeah, thank you. And I think for all of you, we'd love for you to share the knowledge of this webinar with your postpartum team, right? Because it's making those connections to research that's going to end up helping us change practice. And sorry for the technical issues here. We're doing a lot of fancy dancing work here behind the scenes. Could you briefly speak about hand expression versus pumping and the effect on milk production levels with when initiated early and often?
Great, thank you for that question. So, hand expression is nice in that it allows us to remove some colostrum and get that easily. What hand expression does not do is it doesn't provide the vacuum that a healthy term baby would do to actually cause that change from secretory differentiation to secretory activation. So there are older studies published by Jane Morton about hand expression that a lot of people widely cite. But if you actually look in detail in her two publications, the participants actually didn't have normal milk supplies. And remember, our goal for a normal milk supply is somewhere between 500 and 1,000, right? And average is like around 750. So like kind of understanding that the hand expression, while we can get some nice drops of colostrum, it doesn't do the same thing as a baby would do, because a baby has very strong vacuum pressures, which completely empty the breast and also are turning on all those prolactin receptor sites, right? Because that's what we need to do. We've got to boom, 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 rapid fire those prolactin receptor sites so that we can maximize or optimize milk making capacity.
Yeah, I love that because I think it is such an important point that maybe is misunderstood, that like early kind of sucking pattern that the baby's doing is really kind of turning those cells on. And without that stimulation, then in the long term, we don't end up with as many cells that can produce milk. They just kind of stay epithelial cells.
Yeah.
Okay, great. This is, we have so many questions. One is people want to know more about antenatal expression and maybe your paper. They also want to know about this presentation. So if you go in the tab on the toolbar that says apps, Diane has made the presentation available to you as a download, so you can find it there. You can also find your CE credits there for your certificate for joining. Please make sure that you cite Diane when using any of the slides that you are using for your teaching or looking for the research for that. And so just thinking about this with antenatal expression, some people ask, like, what is the mechanism that's happening in this metabolic remodeling that's being so protective for the mother for her cardiac health? Can you
Yeah.
explain that a little bit?
Yeah, I mean, well, you have to think about how lactation works overall, right? So, lactation is so important for like returning blood sugars to normal, right? It's important for glucose metabolism, lipid metabolism. It's helping to reduce insulin resistance, right? It reduces our blood pressure. It reduces our chances of being overweight. And all of those things are linked, right, to heart disease, right? And so, like, if and I always think about things from what is the normal physiological process. Women, if you are, are born XX chromosome at birth, we are designed to be able to get pregnant and to be able to lactate. That is what our body is supposed to do, right? And so that process of lactating and making milk is really important to reset, right, the body from pregnancy. And then think about those hormones of lactation, right? Oxytocin, they call it the love hormone. Prolactin, they call it the mothering hormone, right? Um, these hormones are so important for our postpartum well-being, right? They're important for reducing stress. They're important for our mental well-being. Like all of these things that, are going to impact our cardiovascular health, both short term, but also long term.
Yeah, it's such a great point, and this is a really expansive topic, right? I think we can probably provide some resources to the participants. We can send them out after, where they can find information about the remodeling, because I think when you're talking to your healthcare team back home, you need some support for them to understand why it's so important. And I know for sure this is always an issue where I work too, is trying to get these moms pumping frequently in that first 24 hours. So, Diane, we want to thank you so much for your time. This has been a great webinar. Thank you, everyone who has joined us. You'll receive a survey right after the call is ended, and we really appreciate all of your participation. So, thank you.
Thank you, everyone.